We're gonna set up for an emergency craniotomy. I've always been interested in science and just to be able to see the human body. Not very many people get to see the inside of a person's skull. It's different. It's completely different than being on the floor. We get the patient in the room, we get them prepared for surgery, the positioning, prepping, everything. If you don't like the sight of blood, don't come here at all. At all. Because you'll see a lot of blood. I work 12-hour shifts and take calls, so I could be here for over 24 hours. Right, I'm just gonna put an oxygen mask on you, okay? You're kind of the manager of the room because the doctor's busy doing the procedure and you have to make sure everything else runs smoothly. This is some of the medications they use for cranies. I'm just mixing. You have to be pretty detail-oriented because it is fast-paced. I think it's more fast-paced than the floor. So you have to know always what comes next. You have to know the procedures to make the patient happy, number one. We always like to make the doctor happy because we do work with the physicians so closely here. They know us. Anything that they need to have prior to the surgery, we do. These packets, they come with sterile suture inside, and you have to give it to the sterile field without contaminating it. You can't be real slow-paced because sometimes we are running up and down the hall trying to get things fast-paced sometimes and then slow at other times. Every situation's different. I'm always learning. And I would hate the day that I didn't learn anymore, because then you shouldn't be in the job anymore.
Hey, look, it's Mini-Me! Loren! I'm coming up on my second anniversary in the operating room. It is such a specialized field of nursing that a lot of people don't really know what actually happens in the OR. So today I wanted to pull back the curtain a little bit and show you what happens in the operating room and what specifically I do in my job. Now, as much as I would love to give you a grand tour of my workplace and actually have you walk through a shift with me, I would be violating so many HIPAA laws. So this is the next best thing. My main task as a circulator is to make sure that that patient is comfortable and safe. And you know why they call them circulators, right? It's because we run in circles over and over and over again. In the OR, you need to make sure that you have the proper attire. There are red lines in the hallways of the perimeter of the operating room. When you pass the red line, you need to make sure that you have the hospital-provided scrubs as well as your hair covered. The nice thing about my work is that I'm able to wear all my fashionable scrub hats. So now we're going to start a case. We need to make sure that we have the case cart that is filled by our Central Processing Department, or CPD. They put all the supplies that are needed into that case cart, and then they put the preference card or the pick sheet for that surgeon on top of the case cart. This pick sheet is vital because it lays out all of that specific surgeon's preferences for that case, from positioning the patient to prepping the patient to medications that you might need, even music that the surgeon likes to listen to while he's operating. And then now it's time to open our supplies. But wait, I'm missing something. You can't really open the room until you put the proper mask on. This protects the sterility of the instruments. But a scrub tech might choose something like this because it protects their eyes. I've actually seen blood splurt across the room, so if you're right near that body cavity, who knows what's going to come out of there. Now, if a patient is suspected of having tuberculosis or TB, that's a respiratory isolation condition, and you have to wear a special respirator mask for that. Like this one! So let's talk about the room layout. In the center, you have the operating table. As a circulator, it's very important that you make sure that all of your instruments, all of your equipment works. Nothing is worse than having the surgeon all ready to go and then you turn on your machines and they don't work. First is the electric surgical unit, or ESU, sometimes called a bovie, an electric knife that's used to cut and cauterize. Basically a lightsaber. We open our sterile field, which starts with our back table. On our back table, we put all the things that you're going to need for that case, and we have to open them in a certain way that we don't touch them with our bare hands. Our bare hands. Usually my scrub tech will go and start scrubbing in, and then I'll tie him or her up into their gown. At this point, they are essentially sterile, and I cannot touch them, so no more high fives. And then we count, which is one of the essential things in any operating room. The reason we count is we don't want any retained objects. That means things left inside the patient once they've been closed up. This is where you get really good at doing fast addition and fast subtraction and counting by fives when it comes to lap sponges, tens when it comes to Ratex, and 8 or 2 when it comes to suture. I go to pre-op and I meet my patient. I identify who they are by checking their bracelet with their consent and also their verbal testimony that they are who they say they are. I ask them about their allergies. I ask them about the last time that they ate or drank anything or were MPO. I verify the procedure with them, make sure that we are doing the correct surgery, that they know they're getting an amputation of their right leg versus getting a colonoscopy. If it's a sided procedure, which means right versus left, that they are marked by a surgeon. So once anesthesia's seen them and I've seen them and the surgeon's given the okay, then we wheel them down to their room. So part of my documentation is time. I have to record wheels in time. I have to record pre-induction time, so the time before we put them to sleep. This is an important time. Everybody needs to be quiet and we do what we call a timeout. And no, I don't put a patient in the corner. No, this is a time where we once again verify who they are and what's the procedure that we're doing, and that we all agree that everything I said was correct. So then once the patient is asleep, that's when anesthesia gets to work putting the tube down that person's throat, which is called intubation. This is when we prep the patient. We put some sort of fluid on that area to decontaminate it. After making sure that the prepping solution is dry, the surgeons come in and I help gown the surgeons, and the scrub tech gloves those surgeons, and we put the drapes up sterilely, and then we plug in all the necessary equipment, and then we're ready for our next timeout, our pre-incision timeout. And we all agree on it, and then the doctor says, "Scalpel, please." And then throughout that whole procedure, I am recording what is going on. I help anesthesia with labs. If the doctor takes any specimens, I record those. I count dirty sponges out of our kick bucket, and we do either 1 count or 2 counts depending on what type of procedure we're doing. And this is one of the biggest frustrations of my job, is that if anything is missing, I have to search the whole room. I record that the surgery has ended. Then as the patient wakes up, anesthesia asks them a bunch of questions, makes them put up 2 fingers, squeeze their hand. And if they're following all of those commands, then they're able to extubate the patient, which means taking the tube out of their throat. Some patients wake up like tigers. They're just like ready to fight as soon as they wake up. So I've gotten pretty good at wrestling patients down because they're on a narrow bed, and I want to make sure that they're safe. Once they've been extubated, we move them over to the stretcher and we transport them to the post-anesthesia care unit, or PACU. And then we repeat that over and over and over again until my 12-hour shift is done. So along with keeping the patient comfortable and safe, it's more complicated than that. I have to make sure that everybody in that room is happy. And sometimes you'll have 4 different people all talking to you at once and wanting something from you. Sometimes I feel like I'm just a glorified gopher. I feel like I've found my niche in the operating room. Sometimes I just have to stop and look and say, I really get to see some awesome stuff. Not many people have seen a still beating heart taken out of a patient and a new one put in. Not many people get to see a tumor this big removed from a patient. And the majority of these patients, I don't know what happens to them once they leave the operating room. I'm not providing direct patient care. But the fact that I get to be a part of that care a little bit is kind of cool. I'm the musical nurse. I'll see you guys next.